Okay, welcome everybody to this meeting of the Leicestershire Health and Wellbeing Board. For those of you that don't know me, I'm Ewan Walters. I'm a Democratic Services Officer here at the County Council, and I'm covering this meeting today for Rosemary Whitelaw, who's on leave. So just to remind you, this meeting is being broadcast live via YouTube, and it will be archived so you can view it after the meeting. Following the annual meeting of the County Council last week, the board needs to reappoint its chairman for the next municipal year. I will therefore move straight on to item 1 on the agenda, which is appointment of chairman. And in line with the board's terms of reference, you are asked to note that Mrs. Louise Richardson, as the County Council's lead member for health, has been appointed the chairman of the Health and Wellbeing Board. And I will therefore hand over to Mrs. Richardson to take us through the rest of the agenda. Thank you.
Thank you, Ewan, and welcome everyone. We'll move on to item 2, which is minutes of the previous meeting. I propose that the minutes of the meeting held on the 23rd of February 2023 are taken as read, confirmed and signed. Are you all in agreement? Thank you. Item 3, urgent items. There are none. Item 4, declarations of interest. Do any members have any other interests they wish to declare in respect of the agenda? No? Thank you. Item 6, we have my position statement. You have all had copies emailed to you, and a version is also published on the Council's website. So do any members have any questions regarding the update? Great, thank you. So we'll move on to item 6, which is the Integrated Care Board 5-year Joint Forward Plan, pages 11 to 114. Sarah Prima, Chief Strategy Officer for the Integrated Care Board, and Rashna Vyas, Chief Operating Officer for the ICB, will present this report. Thank you.
Rashna's not here today, so I'll take the whole item if you don't mind. So thank you everybody and good afternoon. So I'm here to talk about the ICB 5-year plan. I want to just give you a little bit of background and the key focus of our plan. And then I can take any questions or feedback that you might have. So just bit of a legislative recap. Integrated Care Boards came into existence in July 22. They were replacements, if you like, for the old clinical commissioning groups and have responsibility for organising healthcare across the system. And our system is obviously Leicester, Leicestershire and Rutland. One of the requirements of the organisation is to have a 5-year plan, and any good organisation should have a long-term strategic plan. So this is our first production of our 5-year plan. It is required in legislation, so it is part of our legislative makeup that we have one, and we are going to be required to update it every year. We were given some guidance from NHS England on what they wanted to see in the plan and a timeline for publication, which requires the plan to be published by the end of June of this year. So we started the development of this plan in autumn with a number of workshops and with the board in particular agreeing sort of high-level priorities and where we wanted to focus our work over the next 4 to 5 years. And then since then, we've been working across the partnership and across the system with all our existing groups, etc., to develop the detail of the plan that you see in front of you today. It's very well grounded in public insights and what we've learnt from the public over the past few years. And you'll see in the plan that there are some a detail of how we have included those in our plan. The big things, obviously, that the public tell us about are things like access, weights and continuity of care. And I hope you see some of those important things coming through in the plan, particularly around elective care recovery and primary care access. It sets a set of pledges which link to our priorities and also link back to those insights that I've just talked about. And we will be developing some outcomes that sit alongside those priorities to gauge over the next few years how well we've done against those priorities and pledges. We thought it was important to make some commitment to the public about what we were going to do, and that's why we framed them as pledges. Chapter 3 is the meaty part of the document, and it really sets out how we're going to deliver our focus areas and link back to those pledges and insights. and that very much focuses on prevention, keeping people well, and better outcomes for patients. So it covers things like prevention, keeping people well, making sure people get access to the right care at the right time in the right place. We talk a bit about community hubs and how we might integrate care at a community level, elective care, children and young people, learning disabilities and autism, mental health, and women's health, including maternity. So we've underpinned that by sections on workforce, finance, digital, things like population and health management, and grounded in our clinical strategy, which is also set out in the plan. We can't have a plan that just focuses on delivery areas without some of those underpinning areas being as strong to support the delivery of those. Hopefully you will see it's aligned to the health and wellbeing strategy. So we're talking there a lot about the life course approaches, and some of the focus areas are similar, particularly around prevention, health inequalities, etc. And there is also a focus on improving access, quality, prevention and health inequalities, which will lead to better outcomes for patients and better value for money for the NHS. So there is a requirement that the Health and Wellbeing Board give an opinion on the plan and whether it's aligned to the Health and Wellbeing strategy. So I'll open it up at that point, Chair, for comment or feedback. The other thing I would say, if people want to feedback outside of this meeting, please do so, because we will be gathering all feedback over the next couple of weeks to produce a final plan for the end of June.
Thank you, Sarah. Does anyone have any comments or any questions? Mike?
Yeah, thanks, Sarah. Probably a bit of a leading question as part of the next steps, I'd imagine. I suppose if I look at it, you're right, it does dovetail with the health and wellbeing strategy because we've used the same framework in terms of the life course approach. It's probably the next step and not for the plan, but in terms of then aligning the delivery plans, I guess I'd sort of value your thoughts on how we do that. And it might be something for Victoria as well, because what I'm thinking is we'll have an operational plan, delivery plan for the health and wellbeing strategy. We need to develop one for the joint 5-year forward view. As I say, it's a leading question. Just one of those answering your own question. Yes, we do need one, but I suppose what do you think and where should we do it? Is that Health and Wellbeing Partnership or Health and Wellbeing Board or a bit of both?
So we are producing one. So when we get to the 30th of June, we'll have an annex that's got a bit more detail in about the delivery. I think we then need to make sure that those two things align, and we need to make some agreement about where certain, because what I don't want to do is duplicate effort and resource. So I think there are some really clear things that are deliverable through the health and wellbeing strategy, and I think there are some things in here, particularly the stuff around elective care, primary care, etc., that are probably embedded in an RCB delivery in particular. So I think we probably need to get together with the Health and Wellbeing Board officer leads actually after publication and just make sure we haven't got any misalignment or uncertainty about where things sit. Would that work? Yeah.
I think that's a positive step, Sarah. Thank you. Nikhil.
Thanks, Chair. Thanks, Sarah, for the paper. I think Mike's kind of asked the question I was going to ask in terms of delivery. But in terms of the paper, I think this is just gone up to engagement as well with relevant stakeholders to get feedback on the plan itself. I think having read it, it looks like it seems like a solid plan. It looks like the priorities are there. There's a plan in terms of how we get there as well. But I think for me, it would be interesting to see how this actually translates into what this actually looks like in the next couple of years. Thank you.
Thank you. Any other questions, comments? Okay, so the board is asked to note the contents of the report and the Leicestershire and Rutland Integrated Care Board 5-year joint forward plan, and to provide a statement of opinion on whether the plan takes account of the Leicestershire Health and Wellbeing strategy. The suggestion is the Health and Wellbeing Board agrees that the 5-year joint forward plan takes account of the Leicestershire Health and Wellbeing strategy. Are all in favour of that? Yeah, thank you. Move on to item 7, which is a progress report on community health and wellbeing plans. This report provides an update on the progress of the 7 community health and wellbeing plans across Leicestershire. And Sarah Lewis, Sarah Lewis, Senior Planning Manager for the Integrated Care Board, will present this report. Thank you.
Thank you. Chair. So yes, this report is for the board just as an update on where we are with the 7 community health and wellbeing plans that are being developed across the county. In terms of just some brief background of where this came from, in January 2021, the Department of Health and Social Care published the white paper around integration innovation, and this outlined a duty for the NHS and local authorities to collaborate with the introduction of health and care partnerships to support integration and support place-based joint work. We've got partnership working already across various levels across LLR, and the place-based work is being driven through the joint health and wellbeing strategies, which are serving as the place-led plans for Leicester, Leicestershire and Rutland. However, across Leicestershire County, there are very large variations in terms of the population demographics and the residents' needs and outcomes. So the community health and wellbeing plans are there to understand and improve the health and wellbeing needs of the more local populations by identifying and addressing key priorities and issues in those areas. What they do need to do is inform the Leicestershire Joint Health and Wellbeing Strategy and respond to the priorities that are outlined within that strategy at a neighbourhood level. So the community health and wellbeing plans are being developed on a district footprint, and this is due to the availability of data and ensuring that we align with the lower tier local authority partnerships which are already in place and focusing on health and wellbeing. It's acknowledged that many individual organisations have their own plans relating to health and wellbeing, and the community health and wellbeing plans will really form an umbrella across all of these. They won't contain the same level of detail, but what they will do is reference them and their importance in terms of the health and wellbeing of the local population. It's fine that some of these link plans are going to have a footprint that may be at system at LLR or place, so Leicestershire rather than at neighbourhood. And when this is the case, we need to ensure that there's discussions between the system or place leads to see whether neighbourhood work's also required and whether we feed into or take the lead on anything. That's going to be really key to make sure that we coordinate across the system, place and neighbourhood, making sure that we've got a golden thread to improve the outcomes and making sure we don't duplicate or undertake any contradictory action. And we're already having regular conversations between public health and ICB just to make sure that we get this in place and that it happens. The community health and wellbeing plans will be accompanied by robust delivery plans, which once approved will be monitored on a monthly basis to ensure that actions are progressing, and that will be reported via the government arrangements which are outlined later in the report. So I just want to run through the main stages that we're undertaking for all of the plans, just so that you've got an understanding of the process that's been followed to identify priorities for each area. So the first stage is to establish a community health and wellbeing partnership working group. Key partners are identified and brought together to come together as a working group in whatever format suits that in particular district. So obviously key partners are public health, county council colleagues, district council colleagues, voluntary sector, primary care, NHS providers, and everybody who has a stake in that local population. Some areas have already got a community health and wellbeing partnership in place, while others have decided to evolve these working groups into partnerships going forwards. And these district level partnerships will continue to oversee the development of the action plans and monitor the progress of these on a monthly basis. So following establishment of the group, there is an information gathering process where a robust needs assessment is completed using a variety of sources, including public health data, What we have done is we've collated that data into the categories that align with the Leicestershire Joint Health and Wellbeing Strategy. So we've collated them into population and growth, wider determinants, best start for life, staying healthy and well, living and supporting well and dying well, just so it's on a consistent basis. In addition to some of the public health data, we also carried out analysis in relation to secondary care activity, so where residents were going for health care. We looked at the impact of local housing developments. We took into account insights, local insights from the community from previous consultations with the public. And we also held information sessions with partners around the group, which are absolutely key to sense check the data and make it into really valuable information. So once we had sufficient information collated, a stakeholder workshops held, which have been face-to-face, and a wide range of stakeholders are invited from across that district. So the purpose of these workshops is to provide the information collated to date and review this in facilitated group sessions, asking if the information resonates, does it feel right, is there anything important missing in terms of information or data, and what do the stakeholders think of the emerging themes and the issues coming out within that district. And the result of this is collated and results in what we're calling a long list of priorities, which are issues for that specific area. In order to make this manageable, we've then undertaken prioritisation exercises, and this is really to rank the long list into those areas that all the partner organisations feel should be tackled first and will effectively form the first year of the action plans. Various methods have been used to date. Online surveys have been used, and one district has developed an actual prioritisation tool. And the aim of this is to end up with a manageable number of key priorities that each district feels is reasonable to focus on in that first year of delivery. And it's really important that we get the engagement on this to make sure when they go into work streams for action, they are owned by all the relevant parties around the table. A final narrative plan is then produced and approved by each district, and there are a couple that are attached as appendices, which I'll come on to a little bit later. In terms of governance arrangements, they are outlined in figure 1 of the report. So each district has a local partnership board, which will have the oversight and ownership of the community health and wellbeing plans, and they will regularly report progress into the Staying Healthy Partnership Board and into the Health and Wellbeing Board. The district partnerships will receive the monthly progress reports against their delivery plans. And although they won't have any formal strategic making authority, they will make recommendations to either their respective organisations, the Staying Healthy Partnership or the Health and Wellbeing Board, to help inform their decision making. We found as priorities are confirmed, we're also trying to ensure we don't duplicate, identify key committees where operational updates from the working groups can be taken, just to make sure that we're aligned and there's no duplication and there's clarity around that golden thread going through from system, place and neighbourhood. So that's the approach that each district is undertaking. So I will quickly whiz through the 7 different areas just to give you an update on where they've progressed. So starting with Blaby, work commenced on the plan for Blaby in June last year, and a working group was established in July. A final governance structure in terms of reference for a Blaby Community Health and Wellbeing Partnership has been approved at the last month's April meeting, and the first official meeting of that partnership is due to take place on the 19th of June. So as discussed, an initial needs assessment and mapping the services has been undertaken. We had various information gathering sessions, resulting in a workshop that was held face-to-face on the 12th of January last year. The output of this workshop was a long list of 19 priorities. Within Blaby, they decided to provide a bit more of a scientific and objective approach to prioritising. A prioritisation tool was developed with public health colleagues really helping contribute towards that. Then an exercise was undertaken using that tool with a number of partners, and this has resulted in a short list of priorities. These are just proposed at the minute, and they've been shared with the wider working group. And it was decided last month that we're going to use the month of May to share these proposed priorities with shareholders to make sure that they feel they're right and they're robust and everyone will take ownership of them. So it's been taken to the integrated neighbourhood team, and a briefing note's been produced that can be disseminated to all relevant stakeholders during this month. So the next steps will be to finalise and agree those priorities, map existing work that's being undertaken, write the narrative plan, and then set up working groups to start delivering those plans. So it's hoping Blaby is nearing completion and should be in a position to go live in the summer of this year. Charnwood, the working group was established in October 2021 and has developed into the Charnwood Community Health and Wellbeing Partnership. Again, needs assessments and mapping of services took place. 2 stakeholder workshops were held last summer and resulted in an initial list of priorities. Last September, prioritisation exercise was undertaken by means of an online survey, which was distributed to a wide range of stakeholders. And the priorities shortlisted and agreed were mental health overall, but specifically there was concern around mental health in teenagers. However, we have a mental health working group that are looking at all aspects of mental health, including the cost of living crisis and the impact of that has occurred with on the population. So that's one working group. We also have a priority around loneliness. We have one around dementia, care planning for dying well, and improving support for carers. So the first thing we did was do a service mapping to understand what is already in place. Initial mapping to the Leicestershire Joint Health and Wellbeing Strategy delivery plan has been undertaken to see what actions are in place at that level. We're developing the groups. We actually have some working groups up and running. A mental health working group's established and has a detailed action plan, which is attached at Appendix 1, just to give the board an idea of the work that's taking place. Since writing this report, the loneliness working group now also has a detailed plan in place, as does the dementia and care planning working groups. Carers is probably not going to be a separate working group, as it's a cross-cutting across all of those themes. A draft plan was produced and reviewed by a wide range of stakeholders, with a final version approved by the Charnwood Community Health and Wellbeing Partnership on the 11th of April, and that's attached for information on Appendix 2. It has been taken to the System Executive and to the Staying Healthy Partnership for information. Hinckley and Bosworth are in a similar position to Charnwood. They were working groups established in June 2021. The same process was taken in terms of information gathering, workshop engagements and prioritisation exercises. Within Hinckley, they decided they wanted to take an all-age approach and have priorities relating to mental health, learning disabilities and SEND, carers, cost of living and housing. So they are currently, again, agreeing members of the delivery groups for each of those priority areas. And again, a narrative has been produced and approved by the Hinckley and Bosworth Health and Wellbeing Partnership and taken to the System Executive and Staying Healthy Partnership for information. And that is attached for information as Appendix 3. Melton, the working group was formed in April 2021. Again, the same process has been followed. There has been a slight delay in Melton due to changes of staffing personnel, meaning a review was undertaken last September. However, a prioritisation exercise has been undertaken and they have identified a number of priorities. So they are around supporting expectant mothers, a generic priority around mental health, working towards a system agenda of integration, so community support hub model, supporting digital inclusion, supporting people with 5 or more complex issues, preventing falls, and some preventative work around healthy eating in children, reducing smoking and supporting adults to be physically active. They are also moving towards the development of a community health and wellbeing partnership. Leads are being identified for those delivery groups, and a narrative plan is in development and is currently out for circulation for review, with a final approval anticipated by the end of this month. So hopefully we'll be able to bring that for your information when it's completed. North West Leicestershire, in June 22, it was agreed that they were going to use the existing integrated neighbourhood team as the forum to discuss the priorities, and they amended the membership accordingly. Again, they've been through the process and have undertaken a prioritisation survey. This output's been shared with the integrated neighbourhood team, so the working partnership group for review, and they're just in discussions at the minute with public health colleagues and wider stakeholders around a proposed phase for those priorities. So in year one, they're looking at cancer prevention, hip fracture prevention, obesity and mental health. Year two, looking at breastfeeding, dementia and learning disabilities, and year three, carers and diabetes. So at the minute, that's just being reviewed to ensure that there's capacity, and they're envisaging taking a light touch public engagement on this following the proposed priorities. Good news now is that Harborough and Oby and Wigston have started work due to just pure staffing resources. They hadn't begun. Harborough has now begun work on refreshing their needs assessment and service mapping. Meetings are starting to take place with the ICB, the Harborough District Council, and starting to identify the key stakeholders to set up a working group to progress that work. Same status really in Oby and Wigston. It's just that the hard bit and really crucial bit at the beginning is to make sure we've got the right people around that table initially to start that work. So they will be progressing over the coming months. Just to note, there's been some common themes that have been across every single district, which is worth just highlighting. A huge issue across the board has been mental health. In terms of increased need, increased acuity, and how services are stretched. So I think mental health has come out as a priority across all areas. A lot of that has been due as also because of the impact of the cost of living has been seen within each area, and that's really affected people's mental health. Another common theme has been around carers, unpaid carers, how crucial and important they are to all of us, and how we can make sure that we've got the support in place for them. And the final one really is, despite fantastic communications teams and strategies, there still is a real lack of understanding between all partners of the different range of services that are available, and referral processes, because there's such a vast range out there. And this is even in terms of the public knowledge. So there's a real common thread there around how do we get that better? How do we make that work? At what level do we need to do that? Whether is it system, place or local, or all three? And because that's been a real blocker. Just to note as well, these plans will also consider and address some national and system commitments. So they will make reference to the recommendations made in the Fuller report around the integration of health and social care, COVID recovery, the bringing care closer to home, and generally better use of the voluntary sector and the local communities. So the Health and Wellbeing Board, therefore, just to ask to note the progress of the 7 community health and wellbeing plans at all various stages, and note that the 2 final narrative plans for Charnwood and Hinckley and Bosworth are attached for information. So if anyone has any questions or feedback, I'll be very pleased to try and answer them.
Thanks. Can I just ask a question? Thank you very much for coming and giving the update, because it's very important. Place knows what's going on. You've mentioned a lot about working groups for mental health, dementia, carers, etc., and then delivery groups. How do they feed in to, for example, the subgroup of the mental health for the Health and Wellbeing Board, etc.? Because we can't have that going round us. So how does it feed in, please?
Right, well, we've been having discussions about this and what we are planning to do for each priority that has been agreed within each area. And Victoria and I have started to map what are those key committees that we need to make sure are cited on what we're doing and we're cited on what they're doing. So, for example, in terms of mental health, I will attend the Leicestershire Mental Health place-based group and make sure that they are brought with any updates and action plans, not to get into the detail, to make, as you said, to make sure that there's awareness of information so that there is any duplication that we're doing, we're clamped down on, we're told, and we make sure that we minimise that. It's going to be a work in progress, but we're trying to put that in as soon and as early as possible because, like we've said before, we do not want to be duplicating and certainly not contradicting what's been happening at place. So we were doing a mapping for each of that to make sure that we're going to those right committees and giving them the appropriate updates that they would need.
Thank you. And also just quickly, are public health colleagues having to attend all of these groups? I'm just thinking of resources.
We have said we would. Our preference is that we have a public health representation on each of the working groups, as you said, resourcing wise. At the minute it's been working, we've been having the public health apprentices helping supporters, which has been working really, really well. And they'd be able to come back to their support mechanisms if there's anything they need to take back. There is that issue there. That's where if we can combine like mental health, instead of having several groups, we've combined it into one. I think if there is an issue in terms of capacity going forward, we just need to work our way through to make sure we get that linked in, even if they can't physically sit around that table. But at the minute, they are represented and they are doing a great job, but we'll have to see how that goes in terms of resources.
If you can just link in with Mike and make sure that all's well in public health for me. Sorry, would you like to come in, Harsha?
Yeah, great to hear too about all of this great work that's going on. The thing that I was going to ask about is these working groups. At Healthwatch, we work at local level, system level, and all of that. And I was just wondering how we might get linked in for these groups, either attending the working parties or somehow get linked in, because some of the themes that you've highlighted, we're all also highlighting and finding that that's coming out when we're engaging with members of the population.
Yeah, absolutely. We have tried to get a sort of public perception involved as much as possible, and we've looked at consultations. But if we would be very open and actually actively encourage representation from Healthwatch. That would be absolutely excellent, yeah, because if we can get some reps, that would be super. Thank you.
Barney, would you like to come?
Thank you. A couple of things, if I can. Firstly, when you were naming agencies, but then when I've looked on it, Leicestershire Police don't seem to have a footprint in any of this. So, can we? And the second thing is on the Hinckley and Bosworth report, it says in a recent report published by Leicestershire Police, suicides had increased by 40%. That's not accurate. That's wrong. It's less than that. I would hope we were having a much bigger conversation if it had increased by 45%. There was an increase last year. So can I speak to somebody about making sure we amend that, because it's a public document now? But then also, I've had some requests from other areas about the numbers for specific districts. I'm really happy that people have that. I will give them the relevant information which is safe for people to have. But I would encourage, if mental health is such a significant factor in the availability of it, that we are using up-to-date data, seeing as we have real-time surveillance here.
Thank you, Barney.
Yeah, can I?
Yeah,
sorry.
Sorry.
Yeah. Just in terms of the wider state health, the police have absolutely that. In my head, that wasn't a full and encompassing list. What we have got is we have got a representative from the ICB on each community safety partnership for each of the districts. So within Charnwood, we've been working really closely with the community safety partnership. They've got a lot of youth antisocial behaviour, and we're making that link with the mental health. So absolutely, absolute key partner, and we are working alongside with them. I will absolutely take back that around Hinckley and Bosworth and get that looked at for you immediately. Thank you.
Thank you, Mike.
Yeah, thanks, Chair. So, it's a bit of a silly question. Is there an overall purpose or objective that these plans are trying to get to? And the reason for asking is I know there's a kind of working group and a needs assessment, but I can't work out if people, you can always hang something on a needs assessment to say it's a priority. Whereas if you kind of said, look, the overall objective is to increase life expectancy, you'd give a bit more direction about the areas and what works. So I mean, there's almost a local thing about saying we think it's important, just generally, as opposed to having an objective and giving more direction about process and methodology and stuff.
I think the main, whether it was initially, but I think the main outcome of this work and these plans has been that lower local focus, because Leicestershire, if you look at it across, it can hide an awful lot of disparities. For example, there's often the deprivation level discussion that, the city's very deprived, the county's not too bad. There's actually some pockets of deprivation in the county that are on a par with the city, and we don't want to lose sight of that. So it is that local variation. What I'm finding it really has done is it has brought really close partnership working around that district that people seem very proud and very bought into these plans, because the priorities have come out of data, but the actual real key nuggets of information has come from the people who are on the ground, who are out there seeing the public, who are dealing with the population, whether that be within public health, within the police, within primary care, within the secondary care providers. And that's what's driven these priorities. So it's a combination. It's not just looking at data and benchmarking, it's doing where those stakeholder events have been amazing, the workshops, is it's turned that into real valuable information rather than just data. So I think what it has done is it's given each area the opportunity to tweak the Leicestershire level vision, which is absolutely right and common for everybody, but it's been able to tweak it and get that extra ownership for those smaller cohorts and variations across the districts.
Are you actually going to have action plans behind this with outcomes so that they can be measured?
Yes, there's the example of the there's action plans. Depending on what the action is, will depend whether there's performance indicators. What we have found, which is good because it is showing that we're linking up, is there's very few actions of, not what, nothing's being done about this. There's not a service in place. That's not what we're finding. What we're finding is there is a service in place, but people don't know about it. So how can we make that work? How can we make that linkage? How can we communicate that to partners and public, going back to that communication? So that's going to be difficult in terms of how we measure it, but that will be, are people known? Have we got information out there in the appropriate ways? But absolutely, there's detailed trackers for each of these delivery groups, action delivery groups, whatever we call them, and they will be monitored and held to account for progressing those.
John, you wanted to come in?
Yes, thanks. Just follow up really on a couple of the questions that have already been raised, but one, I think I want to sort of just get some assurance around is going back to Louisa's point. So a couple of the themes that sort of run through all of them are carers and dementia, for example. And we do already have a Leicestershire Carers Plan, which supports the LLR Carers Strategy, and we're just about to engage on a consultation piece around a new dementia strategy, and there'll be a Leicestershire Dementia Plan. So I suppose just some assurance really that these local plans are going to link in with and reflect the Leicestershire Plan is the first point. The second is around it'd be useful if there's somewhere where we could get some information around who's actually in each of these groups. because it mentions the county council. The county council is quite a big organisation, and it could be somebody in my service area, could be somebody in Jane's service area, Mike's service area, or chief executives. So it'd be just useful to know who is involved in each of the groups. And then the last point was around how are the local plans being resourced? Because presumably if there is a local plan being developed with actions attached, they will need some resourcing. So I'm just wondering, how are they going to be resourced?
So the first point around linking in with those strategies you referred to, the first thing to do is map across to the Leicestershire Joint Health and Wellbeing Strategy, which action plan, which refers to both of those strategies. And actually the actions, our local actions, are to make sure we're aware of those strategies. We link in with the people leading on those strategies to basically have the conversation. If there's anything specific we found within a district we'd like to bring to your attention, or if there's anything that you're doing at place level you would like a district to maybe pilot or try. So that's where I was also saying there's very few actions that are physically doing something new. It's about making sure that those districts are linking in with that. Absolutely, it's not about the districts going off and doing a whole new strategy on carers or dementia. So it's absolutely reassuring, and that's the bit that we are trying to work really hard at, because I know that's what everybody, including us, is concerned about. In terms of the working groups, absolutely we can get that pulled together for information, and make sure that the board is happy that we've got the right representation around those groups as well. I have completely forgotten your resourcing. So these plans don't come with any funding. In terms of the time resource of people, that is something that is on top of their everyday jobs, and it's something we're very aware of. The ICB, the information transformation managers and the strategy and planning staff are doing everything we can to facilitate that and make it as easy as possible. So, example, I will produce all the trackers. I try and populate them for the groups just so that they can sit and use their time to use their brains and do the doing. So in terms of that, we're trying to resource that as much as we can. It's an absolute fair point. It's a very valid point. And it's a bit of, we need to see how it goes. Going back to the public health resource, we need to see, does that come up as an issue? And if it does, it's something we'll have to flag here to make sure that people are aware of that. In terms of finances, it's a lot of, we are finding a lot of it is not doing new things, it's doing things differently. So if we can do that without funding, that's great. What we're also doing is trying to help the voluntary sector potentially explore opportunities for funding, and we can help support with grant bids and things like that. So even if there's not a pot of money yet, if there's something we know would be really useful, it's something we can keep in our back pocket to help if the option does come up for any grants, we could be ready to go and put a strong bid in for that sort of area. So it's a bit of a watch it and see, but it's a very valid point, and it's something we'll have to make sure that we keep progress on.
I think John made a valid point about the local authority being a big organisation, and I think sometimes people are asked to go on these groups without the leads actually understanding where the resource is going, and that can cause problems in the authority. So I would ask that the leads are kept informed of where their staff are being pulled, please. Nikhil.
Thanks, Chair. I was just on resourcing. I was just going to say, it sounds like the resourcing is already there, but it just seems like it's not utilised as well as it could be. Is this where the community health and wellbeing teams could potentially look at making, the existing resource more obvious or more usable? So is this purely about comms to the population, patients, and then again with the community health and wellbeing teams which have PCNs, so primary care practices? Is this something where primary care can play a part to kind of almost advertise these services are there, so please use them?
Yes, absolutely. The community teams are going to be key to this. They're in a majority of the actions, they're going to be the operational conduit of how these things happen. Absolutely, it's not everything, but there is such a huge, I can't underestimate the huge emphasis we need to put on just communicating and letting people know what's there. And there's no right answer about that. I mean, I think that's where we need to work. That's where, you know, a GP has got much better ideas of how to connect with patients around certain things, and somebody sitting in strategy and planning wouldn't have a clue. And that's where we're getting really good working with those community health and wellbeing teams, where we've got people from across the different partners to sort of come together and see what's working and what's not working. But absolutely, they're going to be absolutely key in delivering this.
I've probably asked before, but I've probably forgotten. LACs and community recovery workers, are they involved?
Absolutely. They've been absolutely key. They're getting very heavily involved in the delivery plans now, LACs and social prescribers. And a lot of it is around the signposting and making it as easy as possible for partners and residents to know where to go and not have to work hard at working out where to go and when. Christine.
Just a couple of things that have already been asked, so I won't ask them again. The adults department at the county, we're doing a lot of work with the carers to support the carers because we know how valid they are. One of my concerns is, I think Louise mentioned it quite early on, is about not doubling up on work. When going out to Charwood and Blaby are doing certain things, is keeping informed. So what they're finding might be what's in the other areas. And I think we need to make sure that we're, you know, keeping the people informed and not doubling up. And really letting the residents out there know where they can get some of this information. I'm going to say something tongue-in-cheek. Following the local elections, how everything's altered, do you think it's going to alter a lot of how this group's going to work? That's my concern. The work that's done might be undone to the detriment of what's been going on what the public support needs. I think I mentioned it, didn't I, at our lead member meeting. That's my concern, that we've, you know, we might not get the support of all the boroughs. Now it's been, you know, completely turned over.
Yes, coming on back, the honest answer to that is I don't know. It's something we're going to see over the next few months as those changes start coming, you know, into effect, and we see if there's any issues. Again, this is the forum that we need to be bringing any issues, if there are any, to make sure that this board is aware of them sooner rather than later. So no, I've not noticed anything yet, but I won't have done yet. It's very early days, exactly. So no, that's really.
The principle of the plans are founded in facts. So those priorities that have been established have come from facts and information and data. So I think it's difficult to argue against some of those priorities, but it will be about delivery, won't it? And we'll have to see how that goes. Yeah.
I think as well, even though that is the case, Sarah, within the political arena, there can be problems. We'll leave it at that. Anyone else? No. So the board's asked to note the progress of the 7 community health and wellbeing plans with within Leicestershire County. So we're all happy with that. Thank you. We'll move on to item 8, which is the Better Care Fund year-end 2022 to 23 performance. This report seeks approval for the submission of the year-end template, which sets out income and expenditure, performance against BCF metrics, successes and challenges, and statements as to whether the national conditions have been met. John Wilson, Director of Adults and Communities, Leicestershire County Council, will present this report, and Lisa Carter, Integrated Services Manager, is here in support. Thank you.
Thank you, Chair. So yes, this is the first of 2 reports on the Better Care Fund, which will hopefully be seamless through the transition from one year into the next. So the first report is an end-of-year report on the Better Care Fund for 2022-23. The board will note that we are asking for retrospective approval of the submission that's already been made to NHS England. Unfortunately, the timing of the Health and Wellbeing Boards and the timing of the NHS England submissions didn't tally, and therefore we had to take action in advance of the board meeting. So the Chief Executive of the County Council and the Chairman of the Health and Wellbeing Board approved the final version of the submission, and we're now bringing it to the board for retrospective approval. Just in terms of background, the original 22-23 plan was developed in September 22 and approved by the board in December 22. And on the 5th of April, the national team produced the template for the reporting position for the end of year, and that had to be submitted by the 23rd of May of this year. So we have included the detailed submission at Appendix A to this report, but paragraph 10 just outlines a summary of what's in that detailed statement. So the areas there include whether the national conditions have been met, confirmed the income and expenditure within the plan for the 12-month period, and also included a new element around the discharge grant, which was awarded to the ICB and the County Council in December of last year. In terms of income and expenditure, paragraph 11 outlines the total income for the Better Care Fund at 68 million, and paragraph 12 outlines the out-of-turn position on expenditure of 73 million, and the difference between the two figures is accounted for by the additional discharge grant that came in after the plan was approved and agreed. Paragraph 14 then goes on to look at the outcome metrics, and what you'll see is that of the 4 outcome metrics that are detailed there, 3 of them were met in full, and 1 just slightly short by 0.6% on the percentage of people resident who are discharged from acute hospital to their normal place of residence, but nevertheless 92.3% I think is a good performance. So we should be, I think as a board, assured that we are on target with those metrics. Then go on to look at the national conditions. 4 national conditions that were in the 22-23 plan were all met. So the first one being that there was an agreed plan. The second one being that the contribution to maintaining social care from the NHS income was met. The agreement to invest in out-of-hospital NHS services was met, and the plan for improving outcomes for people who are discharged from hospital. All 4 of those conditions were met. So I think I'm happy to take any questions, and Lisa Carter, who developed and submitted the plan, may be able to answer any technical questions that board members may have. But other than that, we're asking for approval in retrospect for the plan submission.
Does anyone have any questions, comments? No? So we're asked to note the performance against the Better Care Fund outcome metrics and the positive progress made in transforming health and care pathways in 2022-23. To note the action taken by the Chief Executive of Leicestershire County Council following consultation with the Chair of the Health and Wellbeing Board to finalise the BCF year-end report and use his delegated powers to approve it for the NHSE submission deadline of the 23rd of May 23, and also to retrospectively approve the year-end BCF 2022-23 template attached as the appendix to the report for submission to NHS England. Are we all happy to retrospectively approve that? Yep, thank you. We'll carry on to the Better Care Fund plan for 2023-25. This provides an overview of progress to date on the submission of the plan, and John Wilson, Director of Adults and Communities, and Lisa will present the report again. Thank you.
Thank you, Chair. So having approved the 22-23 plan, we're now looking at the 23-25 plan. The obvious change there is that this is the first year that we've had a 2-year plan. So we've had the Better Care Fund since 2015. It's always been a 1-year plan. This year we've got a 2-year plan from 23 to 25. The policy framework is attached to this report. So if anybody is interested in the detailed policy framework that sits behind the planning round, we've got that information available to us. The deadline for submission to NHS England is the 28th of June. And again, that probably won't fall within, well, it doesn't fall within the Health and Wellbeing Board meeting diary. So we are asking that the Health and Wellbeing Board delegate to the Integration Executive, who meet on the 6th of June, to review the progress against the development of the plan. And the plan would then need to be, again, probably approved outside of board through the arrangements with the Chief Executive of the County Council and the Chair of the Health and Wellbeing Board approving the plan together with the Chief Executive of the ICB. Just to note that in the 23-25 plan, there are some differences from the previous planning round. The first of which is that there are some changes to the national conditions. So a couple of the conditions are the same. So the first national condition, which is that the plan is jointly agreed by Health and Social Care Commissioners and signed off by the Health and Wellbeing Board, is the same. And the national condition 4, that the NHS maintain its contribution to adult social care, is the same. But the other 2 national conditions are slightly different from previous iterations of the policy. So the first of those is enabling people to stay well, safe and independent at home for longer. And the second one of those is that we provide the right care in the right place at the right time. So they replace the conditions that were around NHS out of hospital commission care and the discharge conditions. In fact, what they probably do is they expand on those. So previous 2 conditions would still be included within these 2, but these are kind of wider definitions. Paragraph 20 shows the increased income as part of the new BCF plan. So that includes now the uplifts to the inflationary uplifts to the previous amounts, but it also includes the discharge funding that goes to the local authority and the ICB. The next point just to raise is that there have also been some changes to the outcome metrics for the BCF going forward. So again, 2 of those metrics remain the same. The social care element of the metrics remain pretty much the same. So the effectiveness of reablement and the number of older adults whose long-term care needs are met by admission to residential care remain the same. But there are some changes to the other metrics. And paragraph 22 outlines the new metrics in relation to discharge pathways and in relation to unplanned admissions, and particularly around admissions for people subject to falls. And then the final point to note is that there is a requirement to submit a demand and capacity model around the intermediate care arrangements in the locality. So this will outline the expectation around the amount of intermediate care that will be required to be delivered and the capacity of local health and care partners to deliver that care. So I think that's probably all I want to say by way of introducing the report. But again, the detail is in the appendices in terms of both the policy framework, the planning requirements, and some of the national templates. Appendix E, just to draw attention to Appendix E, is the assurance document, and Lisa has helpfully started to put some narrative to the assurance document, which gives, I think, board members a flavour of what will be in the overall planning document.
Do you want to come in at all, Lisa? Are you okay?
Yeah, so I'm just about to submit today the first draft to our BCF regional support lead. That is very informal draft, but that will also go to other key stakeholders, i.e. the ICB and to John for adult social care. Then when we've had that initial feedback from today, I'll be submitting that to the integration exec as a draft report for them to feed into. The plans are largely complete at the moment. I'm just literally finishing off the demand and capacity modelling. So rest assured, as per the document that I sent with the papers, we have got elements to fulfil all of the national conditions, the metric requirements, the data around the demand and capacity modelling, income and expenditure. So yeah, it's largely all there, but it's just poor timing that some of that couldn't come today to the Health and Wellbeing Board.
Okay, thank you. Any questions or comments? Mike?
And sorry, Lisa, I'm kind of digging into the detail a bit, so might be one to take up outside. I guess I was reading the metric and the condition around falls in the over 65s. And, you know, I suppose on the top of my head, I'm thinking, does that mean the plan therefore needs to reflect more around falls prevention, steady steps programs, and less about something else? So we got into the kind of that level of understanding in terms of what conditions means, and are we responding to it?
Yeah, so in some ways, Mike, we were pretty lucky because up until about 2017, 2018, falls was one of our local metrics that we had in there. So we were pretty well averse with the actual data element for it. It doesn't directly feed from the public health outcomes framework because that runs a year late. So we actually take local metric data from hospital admissions. And what we've had to do in the narrative section, Mike, is to feed in how we're going to impact on that metric. So we've had to do a target, which looks relatively low at the moment, but what we've done is we've done that alongside City and Rutland colleagues to try and bring us all kind of in line. I think it's a 2.5% reduction in admissions due to falls for the county. And then in the narrative, we have to kind of say all of the things that we're going to be doing and the investment that goes alongside that to help us to meet that target. I'd probably say the gap that I've currently got is that sort of community prevention element to falls, because obviously we do a lot of work about reducing admissions due to falls, but it'd be really good if we could have a little bit about anything that's around that kind of community prevention of falls element, rather than just kind of reducing an admission due to falls. And also that does include work that we've been doing with care homes to reduce admissions due to falls.
Cool. Are you just come back on that one? Are you linking with Liz Orton and Joe Spokes from Active Together? I mean, they're the two obvious links I'd suggest.
Okay, yeah, I can do. That will go into the second draft if that's okay.
Thank you. Jean?
Thank you. Hi, Lisa. I'm Jean Knight. I'm the Deputy Chief Exec at LPT. I was just wondering, because I know that there's been some clarity received in terms of the parity of mental health in terms of the better care funding for this year, whether or not there's any consideration in terms of discharge, particularly for housing and patients that require reablement from a mental health point of view.
Yeah, so also detailed in the plan, I've set out two sections. One is around housing and one is around actually to support people back into the community from mental health facilities. In the narrative, when you see the draft, which will go to providers and partners, I think it goes through the ICB, but I might need to double check the governance of that. You will see that I've actually put a specific section about how we're investing in mental health detox, particularly around housing. We've got about 4 or 5 elements that we're doing, and if you wait about 30 seconds, I could probably tell you the exact amount from my narrative template. So yeah, it's all in there. It is far more detailed than last year, but it does give a really good summary of how we've expanded into additional mental health areas. Let me just find it. Just bear with me a second. Sorry, it's currently about 50 pages long. So we've also put for housing how we're top slicing some of the DFG grant as well. We've got 3 additional schemes for that. But I have got a specific section on mental health. Just bear with. Okay, so yeah, so we've got assertive in reach for mental health, an agency social worker post, a community support worker for the hospital team for mental health. We've got a mental health relationship enabler officer, which is specifically around helping people once they've been discharged home but are still classed as homeless in the community. And then we've got some additional support to Bridge Street Mental Health, which is to have a similar facility that we've currently got in the north of Leicestershire, in the south of Leicestershire. So there's a lot there to support and hopefully reduce detox for mental health.
Thank you.
Anyone else? No. So we're asked to note the content of the report. Note the assurance document attached as Appendix E that details the proposed contents of the BCF plan return against the key lines of inquiry. Authorise the Chief Exec of Leicestershire County Council, following consultation with the Chair of the Health and Wellbeing Board, to finalise the BCF plan prior to the national deadline for submission of the 28th of June 2023. And to note that the members of the Integration Executive will be asked to indicate their support for the BCF plan ahead of the final submission to NHS England at its meeting of the 6th of June 2023. Are we all in agreement? Thank you. Jean, could you turn your microphone off? Thank you. Item 10 is the Health and Wellbeing Board Annual Report. This report looks back over the past 2 years and reflects on what's been achieved and where the board sees itself in the next 12 to 24 months. Victoria Charlton, Health and Wellbeing Board Manager, will present this report. Thank you.
Thank you, Chair. So, as the Chair outlined, this is a reflection on the achievements of the Health and Wellbeing Board over the last few years and where it sees itself in the coming 12 to 24 months. So the focus is going to be around the importance of place, and the report is intended to provide a succinct summary highlighting some of those key achievements and good examples of partnership working. The content of the report is a partnership approach. Oh, you don't hear me, sorry. The content of the report is a partnership collaboration, and each of the Health and Wellbeing Board members has an opportunity to contribute their views. The board are asked to note the contents of the report and to recognise the work needed to further strengthen and develop the board as a place-based leader. So looking back over the achievements over the past 24 months, a lot of work has been done and overseen by the Health and Wellbeing Board, and this really is just a snapshot of some of those key achievements. The list is not exhaustive, and I'm hoping it will just provide some idea of the breadth of work that the board has overseen. At the last Health and Wellbeing Board annual report, there was a reference to the recommendations of the Air Quality and Health JSNA that was published back in May 19. As a result, the Air Quality and Health Partnership developed a joint action plan to deliver against those recommendations. And the table at paragraph 7 just goes through those commitments and the progress made to date. In terms of next steps, the partnership will look to engage with the public and raise awareness of air pollution and the impact on health, and in particular around sustainable behaviour change, focusing on active and sustainable travel. The Air Quality and Health Partnership Plan is currently being updated and it's scheduled to come back to the board in September. In terms of the wider determinants action plan, that sits within the Staying Healthy Partnership, which is the subgroup of the board. And there's some key areas of success that we've seen over the past 12 to 24 months. And that includes the creation of a joint approach between public health and partners to embed health considerations within planning policy. And also work with planning colleagues to map a wider process and practical sign up to embed health impact assessments in the local planning process and a completion of review in the workplace offer. Leicestershire's adult social care services have also worked alongside Hampshire County Council to transform Leicestershire's care technology service offer. And that'll be looking into linking in with other digital healthcare across stakeholders, including the Lightbulb project. The ambitions of that service was to establish care technology as part of the first offer of adult social care, creating an equitable service designed around service user outcomes. And that leads on to the assisted technology dementia pilot. That's part of the Lightbulb project. And the aim of that was to look at how smart assistive technology and gadgets can support vulnerable people, especially those living with dementia, to stay safe and independent while being supported by carers. To date, there have been 210 referrals out of a total of 770 made for service users living with dementia and Alzheimer's. The pilot is still accessible to anyone living in Leicestershire, and it's been extended to March 24 to now enable further evaluation to take place, with the view that it will continue as BAU after that point. The Leicester and Rutland Transforming Care Design Group has also been working hard to achieve the ambitions of the National Transforming Care Programme to change, and that's part of the programme launched in 2012, which looked at the failings of the Winterbourne View Hospital, and those achievements include the Learning from Deaths of People with Learning Disability Review Programme, which supports the promotion of good health and wellbeing of service users with a learning disability and autism, including the creation of a 3-year roadmap seeking to improve outcomes of those with a learning disability and or autism. Paragraph 15 references the Joint Health and Wellbeing Strategy, which, as we know, was approved in February 22. I won't go into too much detail about that, as our next item on the agenda is the update. Paragraph 17 onwards highlights some of those key achievements from each of the subgroups and the work that's been progressed since the development of the strategy. Just picking out some of the key points. The Children and Family Partnership are supporting communities to look at reducing maternity and child obesity, and they're doing that through the Henry programme. Henry stands for health, exercise and nutrition for the really young, and family wellbeing practitioners have been trained throughout the districts and boroughs to deliver 2 12-week courses throughout the year, and that programme is being rolled out throughout 2023. In relation to Integration Exec, the care coordination has been funded through the BCF since 2015, although it's been delivered differently across Leicestershire. Back in 2021, the process for establishing one service commissioned and funded singly across Leicestershire commenced. A jointly agreed and funded model to support discharges has now been developed, and the overall impacts of that are minimising readmissions for patients who do not require further support as services after discharge from hospital, and reducing admission to residential care in the community. Moving on to the Staying Healthy Partnership, the main focus has been around the wider determinants and the impact of health inequalities on health and wellbeing. A number of key work streams that they've been looking at include the cost of living, which has been picked up by the Communities Group, which sits within the Staying Healthy Partnership, embedding health in all policies, and also the damp and mould issues, which have been picked up by the Chief Housing Officer Group. We've got the Mental Health Group, which was the newly formed subgroup of the Health and Wellbeing Board, and that was established back in December 22. The role of that group is to develop and deliver the mental health cross-cutting theme elements of the strategy, as well as some of those other key place-based elements of the mental health agenda. Paragraph then 31 references the ICS and the establishment of the ICB and also the LLR Health and Wellbeing Partnership, and obviously the key role that the Health and Wellbeing Board has had in terms of helping to shape the integrated care strategy and ensuring it's aligned to the Joint Health and Wellbeing Strategy. 33 mentions and goes through the community health and wellbeing plans, as that's been an earlier agenda item. I don't need to go into the detail about that, but that just gives a snapshot of some of the work that's been done in terms of those 7 plans. We've also got the pharmaceutical needs assessment, and that was one of the statutory responsibility of the board, and that was carried out within the last 2 years, and that focuses on identifying the pharmaceutical services currently available and assess the need for pharmaceutical services in the future. We've also seen a number of JSNA chapters that have been completed and published in the last 12 months, and that includes dementia and end of life. A number of recommendations have been highlighted out of those, and and they're going to be picked up through the mental health subgroup and the living and supported well and dying well elements of the strategy, which sit within the integration exec. It's anticipated that the updates will be brought back to the board at some point in the future. And we move on to see the COVID recovery work, and so that's had a significant impact on everyone within the last 2 years. And we've seen a lot of partners working together to reduce some of that impact. In particular, as a partner of the board, the public health delivery team have made a significant difference with partners to communities. And the table at 41 highlights some of those case studies of the community recovery workers and the impact that's been made to support those through those challenging times. As we move out of one crisis, we move into another, and obviously the focus now is cost of living, and organisations are working hard together to coordinate support and advice with a number of funding schemes and programmes running across the county and districts. There's also a website that's been developed with the County Council and key partners, and that provides key information on funding and various initiatives to support and help those communities. And the table there at 43 just highlights some of those place-based support offered to residents. We can see. Building on that place-based offer, we've seen a number of districts and boroughs working collaboratively to support people and communities on a local level. And some of those really good examples include the social supermarket at Charnwood and the Melton UK SPF project, including the light bulb service as well at Blaby. Healthwatch have done an incredible job to keep reaching out to communities during these most challenging times to ensure that we understand the issues that matter to them most. And they've managed to reach a number of people around the local dementia services and the impact that that's had on service provision. It's done some work around the Mental Health Awareness Week and also reached out to Bangladeshi and Pakistani communities to understand what those barriers are in terms of taking up vaccinations. That's kind of a whistle-stop tour of the last 2 years, and then we look forward what we're going to achieve going forward in the next 12 to 24 months. So we're currently in the JSNA cycle, which is running 22 to 25, and paragraph 47 lists those chapters that are currently being progressed or due to be progressed. It will be important to come back and bring those back to the board to seek views to ensure that the chapters have been prioritised and are in line with the joint health wellbeing strategy moving forward. In terms of development of the board, I think it's acknowledged, especially through the one-to-ones that we had earlier in the year, that further development is needed to strengthen the importance of place, which also looks at clarifying the governance structures as well. As a result, a forward plan is currently being developed, and the aim is to hold 2 to 3 development sessions per year. And these will enable the board to focus on the partnership working and identifying some of those key priority areas where the board can really add value. We've got the first development session in July, and that will look at to address some of these factors and help set the direction of the board over the next 12 months. As part of the reporting process, subgroups will also be required to carry out an annual deep dive of their priority areas, and this will provide the board with progress updates and also highlight the valuable contribution that is being made by each of the subgroup. And back in December 22, we recruited a Health and Wellbeing Board project officer. They're now in post, and since coming into post, a lot of work has been done to develop the communication engagement capability of the board, and the focus over the next 12 months will be to look at carrying out a mapping exercise to unpick the resources and mechanisms that are currently out there, highlighting some sort of key opportunities to avoid duplication and just make sure that we're all aligned across the place. We'll also be looking at developing the website, and that will include increased presence on social media. And we're also looking to undertake an initial piece of engagement, which will form part of that Joint Health and Wellbeing Strategy Review, which is due after 3 years. That's it, if anyone has any questions.
Thanks very much, Victoria. I think it really shows the extent of work that's been undertaken. And thank you for pulling it all together. I do hope in future we can have input from partners, and that'll help with the work involved. But does anybody have any questions or comments? Mike?
Yeah, just a quick comment, really. I mean, yeah, thanks, Victoria. It's always, it's one of those ones. There's a lot of stuff that's gone on, which I won't comment on because you've gone through it. Sort of when you said at the start, the work the Health and Wellbeing Board has overseen, there's a bit of me thought, actually, we've overseen some of it, but actually quite a lot of it we haven't quite overseen, and this is the first time, that we've come back to some of it. I'm particularly thinking JSNA chapters and some of the work looking at Kelly around air quality, which have been really useful, but we've not really brought it back here. Now, I'm not suggesting we receive progress reports on everything we do because the agenda would be massive, but I just wonder if we need to consider outside the meeting how we brief board members on the breadth of what's going on in a way that's more than just an annual report. Bit sort of, could be Twitter or board briefing or whatever, or public comms or something like that.
As part of the comms and engagement, we are looking at different mediums, so whether that's a newsletter, plus I'll still be bringing a quarterly report to the board so I can cover it through that as well.
Okay, thank you. So we just note the contents of the report and acknowledge the progress to date. Thank you. And recognise the work needed to further strengthen and develop the board as a place-based leader. I think that's really important in view of the ICS. And it really means the communication that we all talk about has got to be really solid. Okay, now item 11 is Joint Health and Wellbeing Strategy Update. And this report provides an update on the progress of the Leicestershire Joint Health and Wellbeing Strategy 2022 to 32 since the last meeting of the board in February 2023. And Victoria is going to present this report too. Thanks.
Thanks, Chair. So this provides an update to the board since the last meeting back in February, and also to seek approval from the board on the draft proposal for the reporting timetable cycle for the subgroup updates. Just to recap on paragraph 6 and 7, just to reference the board's agreement in December to move to a more flexible way of reporting of the performance indicators so that they're aligned to when the data gets updated, as opposed to just having the quarterly updates, and there's not much change between the data from one quarter to the next. Each of the subgroups have provided an update on progress for each of their life course stages of the strategy, and these are detailed right through from paragraphs 9 to 30. Some of the key headlines to note, I won't go through it all. The Children and Family Partnership, they'll be reviewing their partnership plan over the coming months, and we'll seek to align this with the Joint Health and Wellbeing Strategy Delivery Plan. The updated plan will be shared with the Health and Wellbeing Board for agreement by December 23. A new resource, Ideas to Help Your Child Thrive by 5, was launched back in April 23 as part of the 1001 First Critical Days. The leaflet was developed in consultation with parents and is being shared with families through the County Council, LPT and UHL staff. It's also available on My First 1001 Days webpage. Partnership workshop was held in March 23 to start work on refreshing the Leicestershire's maternity and early years strategy. Another workshop session was held earlier on in May, and that was in relation to the supporting families to be self-sufficient and resilient priority, and that's to develop a revised action plan and establish task groups and leads for the agreed work streams that come out of that. Moving on to integration exec, the delivery plans for the JCG and IDG, both of which align to the IE priorities and also the Joint Health and Wellbeing Strategy Life Course. They're currently rated green with the exception of Falls, I think we said earlier, which is currently amber. This is due to facing challenges in obtaining data and information from DHU, who currently are running a full pilot across LLR. The integrated locality teams concept has been piloted to deliver more person-centred care at home, and early performance improvements have been recorded against processes and timescales since it began in December 22. In terms of challenges, a shortage of nursing care beds across LLR remains an ongoing issue for both community and hospital. Moving on to the mental health subgroup, this has now met twice since the Health and Wellbeing Board approved its establishment back in December. The focus of the initial meetings has been around setting the foundations to enable the mental health subgroup to deliver against the mental health cross-cutting theme priorities. And paragraph 26 lists these initial areas of focus, which include crisis cafes and dementia diagnosis rates. Task and finish group has also been established to determine how to effectively engage people with lived experience. And in terms of next steps, plans to develop a dashboard to help monitoring of progress against priorities is underway. And the Adults Mental Health JSNA is also scheduled, which will further inform the work of the group. Staying Healthy Partnership, then they've been progressing a number of work streams, which includes scoping for a joint pilot project around respiratory, asthma and damp and mould, and health in planning active environment, where public health, ICB and active together colleagues are continuing to collaborate on this work stream and embedding health through the local planning system. And this is in partnership with the Town and Country Planning Association. Pilot work continuing around hot food takeaway policy within local plans is also taking place. There is some general concern across the Staying Healthy Partnership around the pressures of funding cuts and how this will impact on future prevention activities. And a workshop has been planned to help understand what the risks are and agree a collective approach to help mitigate against them going forward. Let me move on to the reporting proposals. In paragraph 30, it details a proposed timetable for reporting progress updates on the Joint Health and Wellbeing Strategy to the board. The guidance has been sought from our business intelligence team in relation to when the data is getting updated and also linked into the subgroups to understand when their work plans and priorities are so that we can align to that. The board can expect to continue to receive quarterly progress update reports on the strategy, but the proposal allows the subgroups enough time between each of the updates to action priorities and demonstrate outcomes. The intended proposal was aligned to when the data gets updated and allowing the subgroups to provide a deep dive into the relevant life course stage. The reports will be provided by the subgroups themselves, as opposed to me giving the update as part of my quarterly update, which will provide a greater detail and rich narrative into the work that's being undertaken. This will allow the subgroups to spotlight specific areas of focus where the biggest impacts can be made. And it should also provide assurance to the board that whilst raising the profile of the subgroups, of the valuable contribution being made. I think it's important just to highlight this is only a minimum requirement, and the subgroups will be encouraged to update the board or bring any urgent matters to the attention of the board outside of these times. So they're not set in stone, but it is a guide. If approved, the reporting timetable will come into effect from September 23. In terms of additional updates and developments, following the feedback at the recent one-to-ones with Health and Wellbeing Board members, which was earlier in the year, it was acknowledged that holding more regular development sessions out of the formal structure of the board would be hugely beneficial and very welcome. So as a result, we've got 2 development sessions that are scheduled for the remainder of the current calendar year. The first will be held in the summer and the second over the winter, and those dates are in everybody's diaries. Over the coming months, the structure of the sessions will be shaped and the agendas will be finalised, and members may be asked to contribute to the shaping of the agenda to ensure discussions are meaningful and collaborative and just sort of have that whole partnership approach. Building on those one-to-ones to sort of help strengthen the board, a short survey has been drafted to seek views of board members, and it's anticipated that these responses will feed into the discussions of the development session. The survey has now been circulated to members earlier this week, and the deadline is 16th of June. It'd be really great if everyone could respond to that, and I will do a reminder near at the time because your views are important. Moving on to communication engagement, so a comms plan has been developed with our LCC comms team, and that's looking at promoting the Joint Health and Wellbeing Strategy. We needed to wait till after the election period, and that includes the video, the easy read and plan on a page document, and that will be a soft launch that's going to be planned towards the end of May and throughout June, with ongoing promotion activity thereafter. We'll also be looking at the development of newsletters and increasing on Twitter and other sort of mediums as well. Something that's not highlighted in the report, but just wanted to make you aware, is that there has been enough opportunity to carry out some initial engagement as part of a small online deliberative discussion group. Kind of coincides with the launch of the Joint Health and Wellbeing Strategy, and it seems to be an opportunity to seek views on the strategy and make sure that the priorities in keeping with what the public are thinking. It's still being developed and we're still in discussion, but I will bring a further update to the board back in September. We're also looking at developing the website, and we're looking at an options appraisal at the moment to see what the options are in terms of scope, and I can bring a further update in September. And that's it, if there's any questions.
Thank you, Victoria. I do want to emphasise that it's a minimum reporting cycle. You know, Health and Wellbeing Board welcome reports from the subgroups and partners, so do put those through. And also just a plea from me really for people to note those development sessions and to have them in their diary, because I think that will be an important area where we can really work together on building the Health and Wellbeing Board into the place structure we need. Are there any questions or comments? No? So we're asked to note the progress made to date and approve the reporting cycle timetable. All agreed? Thank you. Item 12, the Joint Strategic Needs Assessment chapters, Children and Young People's Mental Health and the Health Inequalities. This report provides an update on the ongoing development of the Leicestershire Joint Strategic Needs Assessment and a summary of the headlines, conclusions and recommendations arising from 2 recent JSNA chapters developed on children and young people's mental health and health inequalities. To present the report, we have Andy Brown, Operational Business Intelligence and Performance Team, Leicestershire County Council, Sally Valance, Strategic Leads Healthcare Public Health, Hannah Booth, Public Health Registrar, and Kelly Marie Evans, Public Health Consultant. Over to you.
Okay, thank you. Just a few short words from me in terms of introduction, because you've got 2 really important and comprehensive chapters to get through, so I wanted to leave time for that. We brought a paper to you last year setting out our plans to re-energise and take forward the JSNA chapter development process following the pause that was caused through the COVID pandemic. And it set out a number of chapter priorities linked to the health and wellbeing strategy and data releases. And that work's commenced around a range of topic areas. We also set out the important data that was coming through from the census. That's really a key underpinning element for the range of topics and chapters. And you'll be aware a raft of evidence has come out since last summer and through the winter, which is really helpful to us in terms of really getting a good evidence base now on Leicestershire, the changes that have happened in the post-pandemic environment, and some of that has fed into the chapters today. We are working on the demographic chapter, and we'll look to bring that through to you hopefully at the next meeting as well, to give that broader context of some of the changes that have gone on. But other than that, I wanted to hand over to the experts that have been really involved in developing these chapters. So particularly Hannah Booth and Kelly for the Children and Young People's mental health one, and then later on Sally for the health inequalities chapter. The full chapters are available on the Leicestershire Statistics and Research website, so all the evidence and background information is there if you want to sort of delve into the detail. But we have circulated a summary of the main recommendations, some of the main findings, and also a brief presentation that we're just looking to pull out some of the points from today to sort of bring to life the main findings. So happy to say any questions, or hand on to Kelly for the short presentation.
To just magically make it appear on the screen. Amazing, thank you. Brilliant. So yeah, as Andy said, we conducted a stakeholder group for the children and young people's mental health. I was just going to go through, there is a generic process which I'm sure you're all aware of, so I won't dwell on too much of that, and I'm just trying to pick out some of the key results and recommendations, and then any questions at the end. So to go, thank you. So it was a multi-agency group listed there. You can see, I won't read them all, all the stakeholders that were involved. So when I go through the recommendations, there are recommendations from the multi-agency group, just myself. Thank you. And as I said, it is a process. So we look at who's at risk, what the level of need is in for Leicestershire, what's the impact of that, any policy or national guidance that exists, what the current services are that exist across the county, and then identify any unmet need and gaps and make some recommendations. So we looked at the mental health of children and young people survey for England, and that showed us that there were 18% of 7 to 16-year-olds and 22% of 17 to 24-year-olds that have got a probable
mental health disorder across the country. But if you equate that down to Leicestershire, that's about 30,000 young people that might have a probable mental health disorder. And then when we looked at services and how that impacts them, we have seen an increase in community and outpatient attendances and new referrals into secondary mental health services. And the graphs below, they'll be in the pack so you can see them, but Leicestershire's that blue line. So it is below the national average, but it is still tracking along with it increasing across both of those. So there are protective factors for child's mental health, and they're listed there. So increasing children's self-esteem, and we've conducted a health-related behaviour questionnaire across, it was offered to all schools, primary and secondary schools. Not all of them completed it, but from those that did, then it showed us that approximately 1/3 of children and young people have reported how high self-esteem, but this was lower in girls than boys. Physical activity is also a protective factor for a child's mental health, but only looking at the data, only half of 5 to 11-year-olds and 1/3 of 12 to 17-year-olds did the recommended amount of physical activity. And having a trusted adult in your life is also a protective factor. And then when we conducted the health-related behaviour questionnaire, this is one of the questions, and only half of primary school children have that. So just looking at how we might address some of those, there are some evidence-based models that we recommend. So, and this is across some of the county, we are doing this anyway. So the Solihull approach is a well recognised model for professionals working with children and young people. So how can we ensure that's consistent across those professionals working in the county? Again, the 5 to Thrive model is a well-known model. So is there any way we can improve how that's consistent across organisations? And one of the statutory checks in health visiting is your 2.5-year check. So how can we ensure that we're looking at the ages for stages and that social and emotional development then? We also wanted to explore a bit further around what might be the best approach with regards to building self-esteem. So explore further the evidence-based programmes that might exist to increase a child's self-esteem. And in particular, maybe target some of the physical activity programmes to children with long-term conditions and particular areas in the county. So when we looked at risk factors, deprivation, I know Sally won't go into too much because Sally will give this, but deprivation is one of the risk factors for having poor mental health, and nearly 9% of children and young people under 16 live in absolute low-income families. So again, that equates to about 18,000 young people. Having physical health problems, that also impacts a child's mental health. So we looked at GP records, and there were about 30,000 young people that have physical health problems. And special educational needs and disabilities is another area. Children that miss education or are electively home educated also have worse mental health outcomes. And bullying and cyberbullying obviously affects a child's mental health. So again, using the health-related behaviour questionnaire, there's about 1/3 of year 4 to 6-year-olds and at 1/3 of year 8 to 10-year-olds that reported they felt afraid to attend school sometimes due to bullying. And in particular, that bullying prejudice was one of the areas that really came up. So approximately 7% of primary school children reported being bullied due to prejudice. So be that their ethnicity, colour of their skin or religion. So just picking out some of these recommendations, we do have a trauma-informed approach across the county. So how can we continue to implement that across organisations to ensure that all professionals who work with children and young people are trauma-informed, and also, again, kind of explore those evidence-based programmes for bullying and cyberbullying, especially looking at prejudice. And again, work with the anti-bullying team to better understand some of those underlying causes of bullying. I won't read all these, but these are the groups that were identified as risk groups, and there's the absolute numbers that we've got within the county. And looking at how we might provide additional support for those groups that are at risk. So is there any way that we could ensure that they have prioritised access to mental health support services? There are directories and referral pathways that exist, but how do we ensure that they're accessible to looked after children? And those children in transition. So we do have partnerships with adult services, but is there any way to strengthen those, particularly for those children that are looked after, to make them easily navigatable? I don't mind going on to the next one. So I kind of touched on the services before. We do across the county have a higher number of inpatient rates in comparison to our comparative neighbours. And a significant portion of these are for neurodevelopmental disorders. The chart below kind of tracks where the increase has been of accessing CAM services, with routine referrals being over 80%. And as I mentioned, we do have a large number of children with neurodevelopmental needs, and there are large waiting lists, so nearly 3,000 children on the waiting list as of April 23. A number of those referrals have been about eating disorders, and they've increased by 2/3 from 2018. And the urgent referrals have also increased. Thank you. So from a recommendations perspective, how do we kind of develop and strengthen the role of the voluntary and community sector to support those children, to kind of, I guess, reduce demand and prevent children and young people needing those services in the first place? And how can we explore providing supportive and friendly environments for children with autism and neurodevelopment conditions? So transition to adult services. Again, this kind of shows you access to service provision by age and the drop off at 18. I don't think that's any surprise to anybody, but we do have care navigators that coordinate the transition between children and adult services. And it's just how we can best understand the impact of that service and if there is anything more that could be done. And I think that's probably just a repeat of what I've already said, so that's fine. And then obviously with any GSNA chapter, we look at what we don't know and what might need to be investigated further. So professionals that were part of the group told us that actually there is some anecdotal evidence that anxiety is increasing and the symptoms of it, but we don't seem to record it anywhere. And also they told us that some children and young people are using cannabis use to cope with their mental health concerns. But again, we don't have any data to suggest that one way or the other. So could we investigate that further? And there are other protective factors, such as a good education, someone in the family being in work, and a positive relationship with parents, the type of community they live in and community cohesion, and actually whether a parent's in prison or not. But again, they were all things that we didn't necessarily have access to. So unsurprisingly, the recommendations are to explore how we might be able to capture some of those to see whether they are just anecdotal or is a problem, and how we might use some of those protective factors more. That's it, my last slide. Next steps, all of these recommendations have been put into an action plan, and we will work with the county-wide mental health group and the Children and People's Partnership to make sure those are delivered.
Thank you, Kelly. And you can, Deborah. Thanks. Just one point on the earlier slides, just about the percentage of young children with that wording of probable mental health disorder. It's just a bit wide-reaching. I just wonder what's included in that. Is that children with a clinical diagnosis of a mental health disorder, or is that including anxiety? Because then you refer to anxiety a bit later. So is this just trying to gauge what's within that probable mental health disorder umbrella term?
Yeah, it's how they define it nationally as part of that survey. Without going to look at the definition, I couldn't tell you the exact conditions, but I'm happy to go and read what the definition of probable is and let you know what's actually included.
I'm just wondering if it's including sort of that lower level anxiety, short-term emotional instability and stuff like that, because I think it could be quite misleading, because it's quite a high percentage of young people that we're including in that, and I just think we just need to be clear about what we're actually talking about.
I don't think it is the low level mental health. I think it's more that have got diagnosis, but I will go and check before, because I can't remember the definition off the top of my head. Apologies. Jane?
Yeah, thank you. So really useful and I think really helpful kind of data and insight into children, and particularly around mental health. I guess there's a lot in here, isn't there? And what would be helpful is to kind of unpick what's already happening and where we might need to strengthen what's already happening, but also where there are some, kind of, you've rightly identified some potential gaps in delivery as well. And I guess that's the question, isn't it, around what are those gaps and what needs to happen to fill those gaps. And I'm just conscious of some of the kind of funding decisions that are being made at the moment that might then create a few more gaps in some of this provision as well. And how do we collectively think about what needs to happen there? I'd be really keen to see the action plan as well, just to kind of understand how it links with the points I've just made about what we're already doing and what needs to happen. And then my last comment is around the kind of transition to adulthood. I think that feels a bit light in terms of the support from transition to children's adult services. So I think there is the support of care navigators, but there's a lot more around, because we're talking about transition of young people's care. If we're talking about mental health only, then but I guess we need a bit more clarity, or we need to do a bit more unpicking, because the work around transitioning children into adulthood is broad and vast. I think this is just talking about mental health and is drop off. Yeah, and
I've probably just maybe inaccurately tried to pull out different bits from the GSNA chapter, which was vast. So I may have, not given that part the justice it needed. But it's more about,
felt like it needed unpicking more, but it could be that it's just missed out the summary as well. Yeah, that was all. Thank you.
Thank you, Mike.
Yeah, it was the same question as James, because similarly I was thinking there's a lot of recommendations in there and we will be doing things against them. I was going to phrase it as, have you got a view? Is there a recommendation, like a big thing, where already you'd go, this is an absolute this is a real big miss that we're not doing anything? There's almost like prioritising those gaps and ones that would make you lose sleep at night.
Yeah, there is a lot going on, and Hannah's documented all of the services. So there is probably something around how we coordinate across, especially when I tried to pick out the voluntary and community sector, because they are doing a lot, but how connected that is to maximise the impact that they're having, I'm not sure. I was quite surprised from the bullying stats, but again, I don't know whether that's a true gap or it's just how it's being perceived through some of the questionnaires. That was probably my biggest concern, about we've got a high proportion of particularly maybe our more ethnic groups in schools that are not getting a fair ride in the school, but it probably needs to be looked into further, I would have thought. Okay.
I must admit the bullying figures do surprise me, and a couple of us have been at a district's youth council conference where this was brought up by the students, and I was really surprised, after all the work that we do, that this is still not working. So I think perhaps we all need to look at how we may have to do things differently. But it's a big thing, and the racial discrimination as well. Students are very open about it all, but we have to be the ones that look at the processes that are involved to try and stop it, really. Anybody else want to have a... No? Yes, Jane?
Sorry, just on that, I guess I'm not surprised by those statistics. I think that's the reality as well. So I think that they kind of, I know they're quite stark, but I think certainly in terms of the bullying and cyberbullying, we know there is an increased prevalence of children experiencing cyberbullying, and it therefore impacting on mental health. And it's one of the, we think nationally, one of the key risks for children now. And in terms of not just impact on mental health, but impact on so many other things. So I'm not surprised at that. I'm kind of surprised it's as low as it is, actually. In terms of prejudice, again, I'm not surprised. And I think some of that's about how we do work within schools to enable children to speak up as well. So I guess the positive in that is that children are reporting it and are talking. But again, I'm not surprised, and particularly not surprised in Leicestershire as a result of the kind of demographic makeup. So I think probably the problem is bigger than the JSNA reports.
Okay, thank you. Are we going on to the Sally, is it? Hello, Sally.
Yeah, thank you. Hello. Hopefully, I think we're sharing the presentation, Ewan.
Yeah, I'll load it up for you.
That's brilliant. Thank you. So I'm going to talk to you just briefly now about the health inequalities JSNA. And again, I've done a brief summary. Obviously, there's a lot more detail in the document itself. But if we could go to the first slide, thank you. So health inequalities, hopefully we're all aware, but just to recap, they're the preventable, unfair and unjust differences in health status between different groups, populations or individuals. And I think the important thing is health inequalities are everywhere, sadly. What happens is that some of us experience them more than others. Some people are able and have the resources to be more resilient to them than others. And what this JSNA has set out to do is not to reveal all of the health inequalities that everybody in Leicestershire experiences. It's really set out to identify who experiences the worst health inequalities, with a view to those are the people that we need to reach first of all if we're to narrow that gap between those that have the worst outcomes and those that have the best outcomes. Next slide, please. Thank you. So in terms of the drivers of health inequalities, the main things that sit behind these health inequalities, firstly, it's the wider determinants. So the environments that we're living within and interacting within, the education, the income, the housing that we all have access to. It's our differences in health behaviours, so things like whether we smoke, whether we have a good or bad diet, the levels of physical activity we have, and so on. It's the psychosocial factors, so the support networks that we have around us, the families, the communities, the friends, and how we feel ourselves, so things like our self-esteem and our self-confidence. And it's also about the access to or the experience of health services. And all of those come together and interact together to enable some people to have very good outcomes and some people to have bad outcomes. Okay, next slide, thank you. So in terms of who's at risk, commonly the risk categories are grouped in this way. So we firstly have protected characteristics, the green boxes across there, and you've got some examples here. But your protected characteristics can affect whether you experience health inequalities and what that experience is like, and the outcomes you experience. You've then got the groups, inclusion health groups and vulnerable groups. This is often about your life situation or your life experience. So you've got things there like people who have experienced trauma or people who are carers that can often impact on people's own health and often mean that they have poorer outcomes in terms of their health. And then we also have socioeconomic risk. So those factors in your life about whether you're experiencing poverty or deprivation. And on the face of it, often that poverty and deprivation perhaps doesn't look so bad, perhaps not as bad as the others. But what we've discovered through doing the JSNA work is that that can often really compound the inequalities that other groups are experiencing. So if we took carers, for example, life is often difficult for carers. There are health inequalities experienced by carers, but if you're a carer living in poverty or deprivation, your outcomes are often worse again because that poverty compounds your difficult experiences. And the key there in the red box, and it's the same with this slide in that red box, is this risk of intersectionality. And that just means that you can fall into more than one of these groups. And if that happens, then again, your risk is greater of experiencing a poor outcome. So in terms of the populations that are at higher risk, this is a list of the populations where there is a clear evidence base of poorer outcomes as a result of health inequalities. And you'll see the ones in bold is where there are evidence bases for years of life lost for those populations. And the ones not in bold are about poorer health for those groups. And I think it's important to say that the JSNA, as with many, is a sort of a generalised population level picture. this isn't to say that everybody that falls into these groups will experience poor outcomes or perhaps will experience health inequalities at all. It's simply saying that your risk is higher if you fall into one of these groups, and we need to be mindful of that, and we may need to target some of these populations sometimes with additional support or to enable additional resilience. Okay, next slide, thank you. So there are some key measures around health inequalities, so things that we would often look at within the data. And what's important with health inequality measures in particular is for us not just to look at a Leicestershire level. So if we look at Leicestershire as a whole, outcomes are fairly good on these measures. We do fairly well in Leicestershire, and that's a real positive for us. So for example, life expectancy, how long we would expect to live if we live in Leicestershire. We're currently better than England, significantly better than England in terms of that life expectancy, which again is a real positive. But what that can mask sometimes is variation within neighbourhoods. So what we actually have is some neighbourhoods that are struggling and are significantly worse than England, and we have lots of neighbourhoods that are significantly better than England, and that sort of equals out. So what this work has done is zoned in on those neighbourhoods to understand where we've got neighbourhoods where the outcomes are significantly worse at the moment. So for life expectancy, we have 11 MSOAs or neighbourhood areas that life expectancy is significantly worse. We have some inequality in life expectancy coming across, that's measured at a district level. We have under 75 mortality, where we have 7 neighbourhoods that are significantly worse than England. And we've got a range of socioeconomic measures, so those things looking at sort of poverty, deprivation, child poverty and so on. And we've got 9 neighbourhoods that are significantly worse than England on at least one of those measures. So we can put, what the JSNA has done is put all of those indicators together, all of those measures together into a table, and looked at which neighbourhoods we might be concerned about given current performance, where they've got significantly worse performance for one of those indicators, or at least one of those indicators. And as you'd expect, several of the areas do significantly worse on several indicators. So these are our neighbourhoods that have been identified that would be our areas of target, or that's the proposal through the JSNA. And once again to say, not everybody in these neighbourhoods will be experiencing poor outcomes. There will be people that are experiencing very positive outcomes. There is also an awful lot of resilience within many of these neighbourhoods and within these communities. So it's by no means setting out to suggest otherwise. It's just pointing out that there are some indicators that are showing that there could be improvement and that there may be additional risk for people here. And so we may want to think of that in terms of our focus on health inequalities. Okay, next slide, thank you. So this kind of question of so what, why are we doing the work on health inequalities, and why should it be important to us? Firstly, if everybody in England had the same death rates as the most advantaged, we would be saving between 1.3 and 2.5 million extra years of life collectively. So a huge kind of figure there to consider across the whole population of England. Further to that, there's a further 2.8 million years free of limiting illness or disability that people could be experiencing. So potentially a huge impact for people and for society there. There's also the cost of that illness. So we've got productivity losses of 31 to 33 billion per year. We've got lost taxes and higher welfare payments, 20 to 32 billion per year, and the NHS healthcare additional costs in excess of 5.5 billion per year. So considerable kind of economic impact across England. And we also know that the more deprived the neighbourhood, the more likely somebody is to receive state-funded residential care. And so these neighbourhoods that were selected, those that were selected because of economic challenge, may well lead or contain currently higher proportions of state-funded care packages. So an important link up there. Next slide, please. So I've lifted a few recommendations here. This isn't the full set of recommendations from the chapter, but some highlights and some key points. Firstly, the chapter recommends a united focus on our populations of concern and our MSOAs of concern. So you will have seen from the drivers back on the earlier slide that health inequalities aren't caused by one single thing and won't be tackled by one single agency. So this is about all of us recognising that these are populations and areas of concern, and that united approach is likely to bring about the biggest impact. We could consider, if helpful, audits of our key services to think about what extra steps we're taking to target those populations and those neighbourhoods, or to remove the barriers to access that perhaps people might experience. We could also consider how to target our preventative services and those that tackle wider determinants on the at-risk populations and at-risk neighbourhoods. We can consider these neighbourhoods if we're setting up new services or hubs, think about how people could access, if they're physical services, how could they access from those neighbourhoods? Are there routes through to people being able to travel there? If we're needing to reduce or target provision more, have a think about those priority populations and those neighbourhoods, and what can we do to protect or mitigate to ensure there isn't too great an impact on those populations. And also to think about how we use our position as an anchor organisation. So things like social value, we're all procurement agencies, many of us will be procuring, that comes with some social value benefit. How could we target that on our populations of concern? And how do we encourage and support people from these groups into our workplace and remove the additional barriers they may face in gaining access to work in our agencies? So as I say, just a snapshot there of the recommendations. So I'm very conscious of time. I've taken you through the kind of key headlines there, but obviously happy to take any questions or any comments on that. Thank you.
Thank you, Sally. Yes, Sarah.
Thank you, Sally. That was really helpful. So I don't necessarily disagree with some of the actions that are in that final slide, but I was at a voluntary community and social enterprise alliance meeting this morning that we've set up as part of the NHS, and one of the studies that came through from that was about how we interacted with the Somali community around vaccinations. And our learning from that is it's much more about getting into these communities, about asking them how we can adapt our services, or what do we need to do to improve uptake. And I didn't see that sort of side of it coming through in these slides. So I really do think we need to put some focus in working really closely with communities and asking questions about what would make it easier for them to access services, or to take services up, or to take screening up, rather than saying, how would we break down barriers to allow people to come to a existing facility or whatever. So while I don't disagree with some of those things, I do think a lot of the emphasis about tackling some of this thing is about changing the narrative going forward. Thank you.
Thank you.
Oh, sorry. Did you want to come back, Sally?
Sorry, do you mind me just adding to that? Thank you, Sarah. It's a really good point, and that is picked up in the recommendations. That's about the ones I've selected for the slides that mean that's not coming through. So it is in there, be assured. Thank you.
Thanks, Sally. Mike?
Yeah, thanks, Sally. I was going to say, I mean, thank you for doing something that kind of addresses issues within Leicestershire, and it's not supposed to be disrespectful to the city. I know when people say that, it means they are being disrespectful. But if we were doing this conversation in the city, we'd just talk about deprivation, and for a very good reason. It'd be like, no need to get beyond that first base, because the levels of deprivation are such in the city, you just need to address that first and foremost. For us, it is more nuanced, and I really like that way you pulled out the inequalities across a number of things. Didn't matter if it was learning disability or looked after children or homelessness and the rest of it. So there is something in there that kind of I'm looking at going, yeah, that's a bouncy thing about health inequalities. The follow-on, I guess, is a little bit like Sarah's point. There are kind of suggestions on the last slide. But I was wondering if you had a kind of, well, putting words in your mouth a bit for this one. Are you sort of suggesting that we need to, as partners around the table, follow a process which is auditing our services to see to what extent we can show how we are delivering for those inequalities groups that you've put on, that we consider what barriers there are? We pick up Sarah's point about the rest of it. I almost want to get this to being a sense of a programme of work we kick off. Some GSNA chapters kind of have a natural home. So the previous one, Children and Young People's Partnership, we know it's been there. The inequalities one runs the risk of being it's everyone's business and nobody does anything. So I'm partly asking you, and I think I'm probably asking for the support of the Health and Wellbeing Board to collectively sort of acknowledge it, and then maybe think about a standard template or something from yourself that we can apply. And again, I don't want to make work for partners around the table because I'm sure there is a lot going on, but I don't just want to have a conversation and then we don't do anything.
Thank you. One of the recommendations in there is for us to consider whether a toolkit or a sort of a process that enables us to do that as individual organisations would be helpful, and to collectively develop that. So absolutely, I think there is a process in there. I think it is about that audit. It is about thinking about these groups when we're needing to change our services in some way. But I also think part of the work is to take this message out now, because I'm finding as I begin to have those conversations with different organisations and teams, people are coming up with lots of ideas themselves within their own organisation, and hopefully if it's approved today and we're able to spread that word further, then I think it's about organisations thinking themselves or teams themselves about what they can do and identifying some of the solutions within their organisations, as well as obviously talking to people affected, and helping them to explain to us what might be some of the solutions along the way. So very happy to develop a toolkit if that would be useful for people.
Thank you, Sally. Anyone else? No. So we're asked to support the findings and recommendations of the Children and Young People's Mental Health Joint Strategic Needs Assessment chapter and approve the chapter for publication, and to support the findings and recommendations of the Health Inequalities Joint Strategic Needs Assessment chapter and approve the chapter for publication. Are we all in agreement? Thank you. Oh, yes, sorry.
Sorry, thanks, Chair. Andy, sorry to come back to you on this one. Again, running short of time. You're right about kicking off the GSNA process again. I just want to check in. Are we making certain that all partners are receiving the GSNA chapters, and particularly thinking about the previous item you may have missed about community health and wellbeing plans, and do districts and locality NHS colleagues receive it? And also our provider organisations, I'm thinking about Rue's work within UHL, Richard, and just want to make certain the system and the neighbourhoods need to receive this as much as place.
Yeah, I think that's a really good point. I think there is more we can do on that. I think there's been a lot of change in the system, a lot of new groups, a lot of new sort of staffing changes with the ICB, ICS coming in. I'm not sure we are totally plugged into all of that, and we need to do better at that as we sort of move that forward. So it's certainly something that's come through from this process that actually there's more to do on those linkages.
Thank you. We'll now move on to item 13, which is the analysis of the health of people with a learning disability using the Aristotle system. This report provides a summary of the findings from analysis of GP record data viewed through the Aristotle system in April 2023. Kate Allardyce, Business Intelligent Delivery Lead, and Sally Vallant, Strategic Lead Healthcare, are joining us online to present this report. Who's going first?
Thank you. I can kind of introduce that. Thank you very much. So I'm very conscious of time, so we can take you briefly through this this presentation. As introduced, I'm here with Kate today. I know Kate is kind of the expert on the system, so I don't know whether you wanted to just briefly mention the system that we've used for this work, Kate, before I take us through the slides.
Yes, I can do. Hi, thanks, Sally. So yeah, this is a system that uses population health management. It's a bespoke tool that was commissioned by LLR CCGs as they were, and obviously now into the ICB. And it takes a variety of data sources, pulls it into one system, and then users are then able to look at pseudonymized data sets. And the one that obviously Sally's particularly interested in is around learning disabilities. So that's just a very high level overview of the system that Sally's used.
Thank you. Okay, if we could have the first slide, please. Thank you. So just very briefly, this is pulling from all of those different places. This is a record viewed on the 18th of April, so about a month ago. We have fields that generally are reliable once you're 14 years or over, perhaps slightly less reliable under 14 years, as there isn't extra work going in to ensure the accuracy of those records. So we just need to be conscious of that. We can't see everything about everybody's health on here. So this is limited to about 15 conditions at the moment. So we need to be careful not to make an assumption that we can see the whole of somebody's health. And data's been rounded, just to let you know. So if perhaps you're noting that some totals aren't quite adding, that will be down to the rounding. Okay, I'm going to whisk through the first few slides quite quickly because I'm conscious of time. Just to give you the headlines, we've got just under 5,000 people on the Learning Disability Register that are registered with a GP that's based in Leicester, Leicestershire and Rutland. So the important thing about this data is that we can't see people's home address or which local authority that belongs to. We can only see where they're registered with. So we can make some assumptions that if you're registered with a GP in the county, you're likely to live in the county for the majority of people. So 2,690 there registered with a GP in Leicestershire. Next slide, please. So age and sex, again, we can group people, those patients registered with a learning disability. We can look at those through age and sex kind of lenses. So we can see, as you would expect, a majority there of working age adults, and that there are more men than women registered with a learning disability. Next slide, please. So what we can also see through the system, which is an interesting piece of data, is how many people live in each of the deciles of deprivation. And you're probably used to looking at 20% most deprived. That NHS Core 20+5 looks at the 20% most deprived neighbourhoods. And when we look at people with a learning disability, we can see that 22.5% of our population across Leicester, Leicestershire and Rutland live in the 20% most deprived neighbourhoods. And that compares to 13.4% of the non-learning disability population. So that means that significantly more people with learning disability live in the 20% most deprived areas than people without. And for Leicestershire, we can see that's 5.4% living in the 20% most deprived, and that compares to 3.2% if you don't have a learning disability. Next slide, please. I'm going to skip this one because it's a lot of detail and I know we're short on time. This one is about the risk categorisation that people fall into. So each of us if we're registered patients within Leicester, Leicestershire and Rutland, have a risk categorisation, and we're grouped into different groupings according to our health. And as you might expect, people with a learning disability are generally falling into that complex health issues grouping, so showing that people do have that complexity to their health. And so we've got the largest cohort falling within that group. Next slide, please. You might be aware that people with a learning disability are entitled to an annual health check. And as at the time when this data was extracted, we had just under 75% of people that had a current health check. Crucially, what this allows us to do is to look into the details of those people that don't have a current health check the health checks are really useful in picking up perhaps undiagnosed conditions, at spotting deterioration of patients, and of ensuring that management of existing conditions is working, and that people are receiving the best treatment. So those that haven't had the health check are quite an important cohort for us, because we know less about them, and there's a chance they might have had something missed. So it gives you a bit more information that we can delve into there. Next slide, please. So we know from the national picture that there are a number of conditions that people with a learning disability are more likely to have. So mental health problems, epilepsy, under or overweight, dementia. And we also know from the LEADER programme that the common causes of death are COVID-19, circulatory, respiratory, cancers, and nervous system diseases. So in the blue text there, you can see what we can achieve from Aristotle in terms of seeing local data. So that shows that we have a mixed picture in relation to those conditions, but that we can certainly get at least part of the picture from that local data. And I'll take you through that next slide, please. So what I've done here is taken everybody that is registered with a GP in Leicester, Leicestershire and Rutland, and we've grouped them into two groupings, those that have a learning disability and those that don't have a learning disability. And we've looked at what proportion of each of those populations has one of the following conditions. So that list there, bipolar depression, so on. And then we've looked at whether the proportion with a learning disability is significantly higher than the proportion without a learning disability. And you can see the record of the outcome of that in that right-hand column. So we can see that for 9 conditions, you're significantly more likely to have them if you have a learning disability. It's significantly higher in our learning disability population. For 2 conditions, it's significantly lower in the learning disability population. That's hypertension and COPD. And I'd ask you to remember COPD for a moment, because I'm going to come back to that. And there is no statistical difference in the proportion of learning disability and non-learning disability populations with 4 conditions. Okay, next slide, please. We can see from the data that the most prevalent condition for people with a learning disability is asthma, and that's followed by hypertension and diabetes. And we can look at where we've got the biggest difference between people with a learning disability and those without, and the conditions they have. And the biggest difference in condition profiling is severe mental illness, hypothyroid, and autistic spectrum disorder. Okay, next slide, please. So what we went on to do, you remember that we took all of the patients in Leicester, Leicestershire and Rutland, split them into 2 groups, one with a learning disability, one without. We then took a bit of a dive just into the population that lived in the 20% most deprived areas. So when we just concentrate on the 20% most deprived areas, we see there's a significantly higher proportion of people with a learning disability and a condition than those without a learning disability and a condition. And that's the case across all conditions apart from bipolar and autistic spectrum disorder. So you remember from that earlier slide, it was 9 conditions you were more likely to have if you had a learning disability. That's now jumped to 13 conditions that you're more likely to have if you fall into the 20% most deprived area. And the biggest difference between those conditions is now COPD. So you remember that COPD you were less likely to have if you had a learning disability. If you live in the 20% most deprived area, you're now much more likely to have COPD. So that's 40% of the learning disability population in the most deprived areas in comparison to 16.5% of the non-learning disability population. And the other condition there is heart failure, where it's 33.3% in the LD population and 10.8% in the non-LD population. Okay, next slide, please. A couple of notes of other data that we can extract from the system. So we can see that nearly 40% of people with a learning disability have 5 or more chronic conditions. and that's over 4 times more than the non-learning disability population. So again, more evidence there that there are more health conditions present in that population. And you're at higher risk of emergency hospital admission over the next year, 4 times higher if you have a learning disability. Okay, next slide. So I've realised that I've fired an awful lot of data at you quite quickly. So to try and kind of sum up, I think this gives us a really good insight into the size of our registered population. It's the best measure I've seen so far, but there may be others out there that perhaps give us more insight, but certainly a very useful tool when looking at the population overall. We can see that you're significantly more likely to live in high deprivation if you have a learning disability than if you don't. And we can see that people with a learning disability are more likely to have health conditions than those that don't have a learning disability. So 4 times more likely to have 5+ chronic conditions, and we can see what those common conditions are. We can also see that significantly more people with a learning disability and a health condition live in the 20% most deprived areas. That's particularly the case for COPD and heart failure. So some of the questions that are coming out of this data, I would always ask the question about whether we're targeting enough on the 20% most deprived areas generally when we deal with health inequalities. But I think what this helps us to understand is that we need to ensure there's a focus on populations such as our LD population as part of that 20% most deprived work. And finally, our LD population is 4 times more likely to be at risk of emergency admission. And again, the potential there to try and prevent with this group specifically. Okay, that's taken you through the data that I hope has helped to evidence some of the inequalities there and to show the beginnings of some work to then take that forward and use that understanding and the insight that we now have. Happy to take any questions. Thank you.
Thank you, Sally. Mike?
Yeah, sorry, me again. So Sally, yeah, cheers for that. I think this was commissioned with a small c by health colleagues. I think it was LPT. Just want to make certain it's one of those ones, cheers for the presentation, but which way now? What are they going to do with it? Does it link in with the leader program and all the rest? So that's one question. The other was more a comment. I suppose I don't quite know what to do with the deprivation stuff. It's not as if living in a deprived area means you're more likely to develop a learning disability. You are in a deprived area. It's a byproduct of having a learning disability and other conditions, and what that then means to your education, your income, and your life chances. So most things targeting deprivation makes sense, but I don't quite know about that one.
Thank you. If I'm okay to respond, yeah, this piece of work was commissioned by the Health Inequalities, Learning Disability and Autism group. So this helps to provide the evidence base for that group to set their action plans for the year ahead. And so it's come at a useful time. This is going to feed into that action planning process now. So a variety of organisations involved in carrying out that work and in taking that forward now into action plans. In terms of deprivation, absolutely. I think what this shows me is that when we're doing that specific work in areas of high deprivation, if we're looking to sort of target our services or to do some specific engagement or specific service offer within areas of high deprivation, we also need to be thinking about our groups that face that intersectionality. And I think it highlights for me that the learning disability population is certainly one of those groups that we need to be engaging with. We need to be ensuring that we've got a decent offer, service offer, that we need to be ensuring that we're meeting those needs. And it's more sophisticated than just working with everybody in the area. So I think that's the insight that it's provided for me.
Thank you, Nicole.
Yes, thanks, Sally. I guess my question was actually more just regarding the health checks, and just to clarify some of the numbers actually. So are we saying that county practices are doing less health checks compared to city practices? Because mean, normally would it be the other way around? I think county normally pride themselves on more better outcomes when it comes to these kind of areas. So is it just that there's more to do in county compared to city, or can I just clarify that if that's okay?
Yeah, I think it depends what you look at, whether you look at the proportion of uptake in the population or whether you look at the pure number of health checks undertaken. So that data obviously is a month or so old now. What I have done is compared it with other records that are held on health checks. And you know, whenever you compare two data sets, there'll be a slight variation, but it's very similar. We've definitely undertaken more in terms of numbers across the county, but proportionately we're slightly under, is what this is showing us. I mean, we need to remember this data pulls from a number of different systems, so we're reliant on those different systems all being accurate. There is going to be always a few issues around accuracy when you're pulling from that vast a data set, but generally, yes, we're proportionately slightly under is what that's showing us.
Thank you, John.
Yeah, thanks. It's really interesting, and I think provides evidence to support some of the anecdotal kind of conversations we've been having for a long time, really. In terms of the numbers, and I mean, I think there probably is a significant number of people who live in the county who have GPs who are outside the county, actually. So I think that is one issue that we just need to bear in mind when we're looking at these numbers. In terms of the deprivation issue, and you know, there is some kind of national evidence around deprivation and learning disability, but not to the degree that this report suggests. One of the things that occurs to me is, and we've known for a long time that in adult social care, our highest level of demand in learning disability is Northwest Leicestershire and Charnwood, and that would, you know, potentially relate back to looking at the issues that we looked at in the last report around deprivation, areas of deprivation, etc. But in learning disability, I think one of the confounding factors is the number of people who live in either residential care or supported living. And we tend to have residential care and supported living environments in places that are in deprived areas because land values and house prices and other factors dictate where they are. So I suspect that there is an element in this which is not around necessarily where people are born or where people live with families, but where people are placed, which possibly is skewing this. And I don't know how we get underneath that, or even if we need to get underneath that. But I suspect that's probably skewing the figures in terms of the 22% in deprivation. And then I was just going to pick up the other points around. I am, you know, obviously aware the Learning Disability Collaboratives, the Leader Group, the Adult Safeguarding Board have had a focus on learning disability for the last 12 months. And we just need to make sure that all of this information is kind of pulled together and is kind of understood in its wider context, don't we? Because, outcomes for people with learning disability, whilst learning disability itself isn't preventable necessarily, the poor outcomes that people experience probably are in many ways, actually.
Sarah.
Just wanted to say a couple of things. Just in terms of the health checks, I just did want to say that City have always done really well with health checks. So but I don't want to get into the dynamics of numbers. But I just wanted to say thank you to Sally really and everybody that's been involved, because I think this is a really powerful piece of work. And more of this type of thing we should be doing to inform our partnerships and our collaboratives around where they need to focus their work on health inequalities. So I think the important thing is to make sure that inequalities group that's responsible for looking at this data actually comes out with a plan and an action in terms of what they're going to do about it, because I think it's really powerful data, and thank you.
Any further comments? Okay, so We're being asked to note the findings of the analysis contained in this report and accompanying presentation, and to support the work of the Learning Disability Health Inequalities Group in coordinating work to address the issues identified. We're all in agreement? Thank you. Can I just say before I go on to the last item, thank you all for staying past the time of the meeting. I always feel that when we come together, it's really important to have these debates and these discussions. So thank you very much for hanging on. And our final item is Young People's Mental Health Special Project. And this includes a summary of the recommendations that have arisen from engaging with young people. And Gemma Barrow, Health Watch, will present this report. Thanks.
Thank you, Chair. Previously, the Health Wellbeing Board considered a report in September 2020 that looked at people's experiences of using children's and mental health services. We've also shared our accessing mental health services during crisis report in May 2021. Since the COVID pandemic, Health Watch have received feedback about young people's mental health services and young people waiting to access services. In 2022, a Health Watch special project was commissioned to investigate further, building on our existing findings. Just going to scroll down. So the report provides a full analysis of our findings and recommendations that are included in the appendix. And now we just wanted to highlight some of the highlights from the findings and what we did. So we made use of surveys to speak to young people, parents, carers and professionals. There were a very small number of interviews with professionals that we wanted to do that didn't pan out in the way we would like to have. So overall, we had nearly 300 surveys completed across the different cohorts. Although there was a low response rate from some of the cohorts, there were some conclusions that could be drawn, and the recommendations therefore were based on the findings. So what we heard was that people who were 17 in the 17 to 90-year-old cohort, their mental health had been impacted by the recent COVID-19 pandemic. And this was echoed from the parents and the professionals that we spoke to in relation to all the age groups of young people. Although young people said that they were accessing services to support them with their mental health, it was not always clear what these services were, although CAMS was mentioned by both young people and parents. Whilst young people were relatively positive about the waiting times for accessing services, there was feedback from parents and professionals of the long waiting times, again, particularly with CAMS. Young people said that they had been provided with support while they were waiting to access services, but again, this was not backed up by the feedback from the parents and carers who had suggested that when young people were waiting to access CAMS, there was little or no support in place for them or the young people that they were caring for. Low-level support was generally seen positively by young people, although there were some comments about the lack of support in schools, and parents and professionals felt that there was too little support for those who were seen as having moderate needs that could not easily be met in school, but therefore did not meet the thresholds for CAM intervention. Young people said that they would like more support in many cases, but did not know where to get it. Again, this was echoed by professionals who said in their experience, young people were not aware where to get help, and that messaging needs to be immediate and regular in order for young people to become more aware. Whilst young people said that they used things to help look after themselves and their mental health, they did not elaborate on what they were using on the whole, and there was no mention from them about the use of alternatives such as creative therapies. None of the parents referenced the use of alternative provision either, other than paying privately to access talking therapies for their young people. Whilst young people reaching adulthood were broadly positive about the support they were getting to move to adult services if needed, most of them also said that they were concerned about accessing mental health services in the future. And parents of young people reaching adulthood said that they had not had information on service transition. So very brief, there are a few more recommendations in the report that we've outlined in there, and all the stats and figures are in the report. So there were 6 recommendations that we have made from our findings. An action plan has been put together against the recommendations and included within the report. We have shared the report with Leicestershire Partnership Trust, and we've asked for feedback on the report and a response to the recommendations and the action plan. And then part of our enter and view programme that we are going to be visiting the Beacon and other services, mental health services in particular, because that's going to be one of our big focuses for this year. So I have
gone through that very quick. I know we're at the end of the session, and all the documents are outlined in the report. The report is, let's say, waiting for responses from LPT, so there'll be more details to follow as well.
Sorry, I wasn't on mic there. Thank you very much. It backs up a lot of the concerns over children's mental health. So we're asked to just report, just to note the report with particular reference to the recommendations and corresponding action plan. So we're all agreed. Thank you. Item 15, dates of future meetings. The list of dates are there. Please put them in your diaries so that we can have a good meetings and with all partners there. Item 16, any other items which I've decided is urgent? No, there are no urgent items, so I conclude the meeting. Thank you all for coming, and see you at the next meeting. Thank you.